The management of atrial fibrillation often involves antiarrhythmic medications, a class of drugs designed to restore and maintain a normal heart rhythm. Navigating these options requires a deep understanding of their mechanisms, efficacy, and, crucially, their potential risks and contraindications. Proper patient selection and careful monitoring are paramount to ensure both the effectiveness and safety of these vital therapies. One critical aspect of antiarrhythmic therapy involves the appropriate use of Class 1C agents, such as flecainide or propafenone. These medications are strictly contraindicated in patients with known coronary artery disease or any form of structural heart disease, primarily due to an increased risk of mortality. The proarrhythmic risk is specifically tied to active ischemia, rather than merely the presence of atherosclerotic plaque. To mitigate this, any patient with risk factors for coronary artery disease, for instance, a male over 40 or an active smoker, must undergo a functional stress test to definitively rule out ischemia before initiating a Class 1C agent. Furthermore, given that ischemia can develop over time, an annual reevaluation is often recommended. These drugs also exhibit negative inotropic effects, meaning they can weaken heart contractions, and should therefore be avoided in individuals with a reduced ejection fraction. Continuing with Class 1C antiarrhythmics, it is always essential to co-prescribe an AV nodal blocking agent, such as a beta blocker. Class 1C drugs are potent sodium channel blockers that significantly slow conduction within the atria. While this mechanism helps suppress atrial fibrillation, it can paradoxically organize atrial fibrillation into a slower, more structured atrial flutter. A typical atrial flutter circuit might run at around 300 beats per minute, usually resulting in a ventricular rate of 150 beats per minute with 2-to-1 AV conduction. However, if a Class 1C agent slows this flutter circuit to, say, 240 beats per minute, it can permit dangerous 1-to-1 AV conduction, leading to a life-threatening ventricular tachycardia with rates in the mid-200s. To prevent this severe complication, co-administration of a beta blocker or a non-dihydropyridine calcium channel blocker is critical to blunt AV nodal conduction. It's worth noting that propafenone does possess some intrinsic beta blocking activity, but this is frequently insufficient to reliably prevent this 1-to-1 conduction. Turning our attention to amiodarone, while it is arguably the most effective antiarrhythmic for maintaining sinus rhythm, its widespread utility is significantly curtailed by an extensive and serious organ toxicity profile. Amiodarone has an exceptionally long half-life, approximately 100 days, and a large volume of distribution. This means that once toxic effects develop, they are very slow to resolve. Potential toxicities include pulmonary fibrosis, which warrants investigation with a CT scan if a new cough develops, and thyroid dysfunction, manifesting as either hypo or hyperthyroidism, necessitating a TSH check every 6 months. Hepatotoxicity also requires vigilance, with LFTs monitored every 6 months. While corneal microdeposits are common and usually benign, optic neuropathy is a medical emergency that demands immediate attention. Given these considerable risks, other agents like Dofetilide, Sotalol, or catheter ablation are often preferred as first-line rhythm control strategies, particularly in patients with structural heart disease. For antiarrhythmics such as Dofetilide and Sotalol, initiation must always take place in a controlled hospital setting with continuous telemetry and serial EKG monitoring. Both of these drugs are Class 3 antiarrhythmics that block the delayed rectifier potassium current, which can prolong the QT interval and elevate the risk of torsades de pointes, a dangerous ventricular arrhythmia. This risk is highest during the initial phase of treatment and during dose titrations. Consequently, a standard protocol dictates a 3-day hospitalization, allowing the drug to reach a steady state. Throughout this admission, patients must remain on continuous telemetry, and an EKG must be performed 2 to 3 hours after each dose to meticulously assess the QTC interval. It is crucial to manually measure the QTC rather than relying on the EKG machine's automated reading, with Bazette's formula generally being the preferred method. Should there be evidence of significant QTC prolongation, the dose must be reduced or the drug discontinued entirely. Furthermore, Sotalol is contraindicated if the creatinine clearance is less than 40, and Dofetilide is contraindicated if the creatinine clearance is less than 20. Among the various antiarrhythmics, Dofetilide stands out as a preferred option for maintaining sinus rhythm in patients with severe left ventricular dysfunction and heart failure. The DIAMOND-CHF trial famously demonstrated that Dofetilide was not associated with an increase in mortality in patients who had recently experienced a myocardial infarction and had left ventricular dysfunction. As a pure Class 3 agent, it lacks negative inotropic or beta-blocking effects, making it hemodynamically well tolerated in this particularly vulnerable patient population.
In contrast, Sotalol, with its beta-blocking properties, carries the potential to exacerbate heart failure, making Dofetilide a safer choice in these complex cases. Lastly, intravenous ibutilide offers a rapid and effective option for pharmacologic cardioversion, particularly when the risks associated with sedation are high. Ibutilide is a unique Class III agent used exclusively for the acute termination of atrial fibrillation and atrial flutter. It boasts high efficacy, with conversion rates often exceeding 60% within just 1 hour of administration. This makes it a valuable alternative to electrical cardioversion for patients in whom sedation and anesthesia pose a significant risk, such as those with tenuous respiratory status. The primary risk with ibutilide is torsades de pointes. This risk can be significantly mitigated by pre-treating the patient with 1 to 2 grams of intravenous magnesium sulfate. Following the infusion, patients must be continuously monitored on telemetry for at least 4 hours to ensure safety. In summary, the effective and safe use of antiarrhythmic drugs landscape.
Adhering to strict initiation guidelines for drugs like Dofetilide and Sotalol, and knowing when to deploy rapid-acting options like ibutilide, ultimately optimizes patient outcomes while minimizing serious adverse events.